So introducing you, the third shining performer is Dr. Prabhjot, who after completing her primary medical career at BJ Medical College, Pune, did her post-graduation at Shankar Dev Nethralaya and then pursued a fellowship in VR and UVR services at LVPI Bhubaneswar and then Visakhapatnam. Her keen interests are in retinal vascular disorders, surgical retina and ROP, with a passionate interest in teaching and works as an ophthalmic educator in the LVPI education team. And to keep you as enraptured, Dr. Prabhjot Kaur, would you take you deeper into the concepts of convergent and creative thinking? On to you, Dr. Prabhjot.
Thank you very much, Dr. Chitra, for that introduction. I'll just share my screen. So once again, good evening, everyone. And I would like to thank Anamika and Megha for very nicely taking us through the history of thinking and then told us about everything that one should know about the 4 types of thinking, which was concrete thinking, abstract thinking, analytical thinking, and divergent thinking. Now, I will be taking you to the last 2 types of thinking, which is convergent thinking and creative thinking. So once again, I'm Prabhjot Kaur, and let's begin with the first one, which I will be taking you today, that is convergent thinking. Now, as the name itself suggests, convergent thinking is nothing but putting different pieces of all the information that is available to you in a logical and an organized manner and helps to come to a definitive diagnosis or a conclusion. Now, this term was coined by Joy Paul Guilford, who also coined the term divergent thinking. Now, convergent thinking, it generally means the ability to give the correct answer to standard questions, and it does not require significant creativity, unlike divergent thinking, which requires a lot of creativity involved, because as many possible solutions one can think of to a given problem involves some amount of creative process. Whereas convergent thinking, what needs is logical reasoning and thinking. Now, we have all been doing convergent thinking when we have entered and basically passed so many competitive examinations where we have been given multiple choice questions. So convergent thinking is nothing but type of thinking that focuses on coming up with the single well-established answer to a given problem. So with this short background, let me now take you through the cases. So starting with the first case is of a lady, 45-year-old, who presented to us with complaints of diminution of vision in the right eye. Very obvious, you can see these ILM folds radiating, right? Along with that, there was a very shallow neurosensory detachment, which was evident clinically. Now, you can see these osities of the right eye and left eye. The neurosensory detachment that was seen clinically was very beautifully picked up on OCT in the right eye, as well as there was a very shallow neurosensory detachment in the left eye. What you see here are these RPE undulations along with hyper-reflective dots in the choroid. So what does FFA show now here? So FFA shows presence of these hyperfluorescent dots, which you can see in both the eyes, along with pooling of dye in the later phases and a very prominent hot disk that is seen here. The B scan showed presence of increased sclerochoroidal thickening. Now with this clinical picture in front of you, I'm sure that all those examples Megha took us through whenever dealing with a patient with exudative retinopathy, we know that we are dealing with something inflammatory because we see here hyperreflective dots in the choroid, then you see a hot disk, and you see increased sclerochoroidal, the thickening, which is very prominent on B scan. So we know that probably we are dealing either with a VKH or a posterior scleritis. So does FFA help in differentiating posterior scleritis from VKH disease? Yes, you have to look for the fluorescence pattern. If you see this presence of pinpoint hyperfluorescence with absence of these very typical early hyperfluorescences, you think of a non-infectious posterior scleritis, because VKH would usually have these early hyperfluorescence on their FFA pictures. So was this a case of bilateral posterior scleritis? Because we didn't see any early hypofluorescences. Possibly, yes. So the reasons that I would give to my diagnosis or to my conclusion is because there was absence of this typical FFA picture as one has described for a VKH disease. Then one can argue, but there was no typical STF that was seen on a B scan. So it can be possible due to two reasons. Now, in our case, the patient was already on immunosuppression. Second thing can be not every case of posterior scleritis will have an STF. Mild cases of posterior scleritis may not have a STF or typical subtenance fluid at the posterior pole on B scan. So hence possibility of a bilateral posterior scleritis more than VKH disease cannot be ruled out. So this is how convergent thinking acts. Basically, you take all that available clinical picture, history, every part of detail which is available to you and try to come to a possible conclusion with the help of correct logical reasoning and basically you try to back it up with literature as well. So this is first example. Now let me take you through the second example. So second example is that of a CNVM. Now this is the same picture which Anamika first showed you, and a concrete mind would say it's a CNVM and stop there. But Megha told us that no, it's not just a CNVM, let us try to figure out more. And she then pointed towards these angioid streaks and told us that it is CNVM secondary to angioid streak. Now, what happened when we looked into the history of this patient? The patient, basically physical examination and history revealed multiple bony deformities. So this was a patient of angioid streaks in Paget's disease. So what happens in Paget's disease is they tend to have because of the early onset, they tend to have a severe bone involvement, as well as because it is an early onset pathology, there is higher risk of angioid streaks in CNVM. So having understood about this second case, so we have dealt with the exudative retinopathy, we have dealt with CNVM. Let me take you to the third example of the same endophthalmitis patient, which first Anamika said that this is acute postop endogenous endophthalmitis. But then Megha told that you just don't stop there. You analyze the picture. So seeing the sclerocorneal involvement and the hypopyon, the corneal edema, the loss of red reflex and all those, and the vision, we knew that this is not a simple acute postop endogenous, but a one which is with the microbial keratitis and a high virulent organisms, most probably. So the patient then was underwent a vitreous biopsy and an IOAB. But what happened is, although you can see the hypopyon reduced in size, but the sclerocorneal involvement which was there has rather worsened here. So what is it? What is causing the worsening of the organism of the infection despite being on treatment? So the vitreous biopsy, the smear did not give us anything, but the culture showed positive group GPC, basically gram-positive cocci groups, and it was a Staphylococcus aureus. So antibiotic sensitivity profile showed us that this was not a simple Staph aureus, but a VRSA. It was a vancomycin-resistant Staphylococcus aureus. So now do we stop here? No, let us try to see what was the source of this infection. Let us converge further. So this was not just a sclerocorneal involvement, but there was a virulent organism which had multi-drug resistance, which was vancomycin resistant. So what we did is we went ahead and tried to look for the source of this infection. So when a nasal swab was taken, it also showed presence of Staph aureus with a similar antibiotic sensitivity profile, which was also a vancomycin resistant one. So then we converged to that the patient was nothing but an asymptomatic nasal carrier of VRSA. So we need to treat the source, then treat the surface and treat the endophthalmitis. And that is how, with proper treatment, a picture which looked like this after the first IOAB, with correct treatment and correct identification of the organism, the patient improved with a very good vision of 21-25. The fundus was visible and the infection was very easy, not very easily, but definitely it took a lot of efforts. But yeah, with the correct reasoning and treatment, we could reach we could eradicate the infection from the eye. Okay, so having understood about convergent thinking, let me take you through the next part or the last type of thinking of today's session, that is creative thinking. Now, creative thinking, the name itself says looking out for new ideas and concepts based on your past learning and experiences. Now, in contrary to breaking the information that we were doing in analytical thinking, what we do here is we break down the information, but then again, we try to put it together in a new and imaginative way. This can happen by either doing, there can be a fusion of two existing ideas, there can be a formulation of a new concept, or this can just be a spark of intuition. Creative thinking, as the word says, means thinking outside the box. It has the ability to perceive patterns that are not obvious. Creative thinking might mean devising new ways to carry out tasks, solve problems, and meet challenges. It brings a fresh perspective to your work. So let me give you a tip of the day here. Now, creativity, just don't get carried away by the term creativity that, maybe it is the one which is just limited to the artistic types. No, creative thinking isn't the one which is limited to artistic types. It is just like any other skill. It is a skill that any one of us can nurture and develop. Now, let us go through a few case scenarios exemplifying what creative thinking is. So this was a patient. Here you can see these 4 macular photograph of the patient showing basically parafoveal graying here at baseline. Again, at 15 seconds, you see there is some reduction if you compare it to the baseline. Now, after 30 seconds, it has almost disappeared, this parafoveal gray. However, after 15 minutes of dark adaptation, there is this reappearance of parafoveal gray. So this is nothing but a case of parafoveal telangiectasia. And what you see is a phenomena that this parafoveal gray was reducing in its appearance and slowly it got disappeared. However, after dark adaptation, it reappeared. So this phenomena was, although PFT has been with us for a very long time now, but this novel clinical sign, which was already there, was picked up by someone because someone who had a different eye towards it, who wanted to look for it, something you keep on observing. So then it was thought that probably this phenomena occurs due to a possible photochemical reaction occurring due to the release of chromophores from the abnormal Muller cells. So this is how how creative thinking can lead to some novelty in already existing clinical conditions, or may help you devise new ways of treating things, right? Okay, so let me take you to the second example now here. So again, a 51-year-old male with anterior chamber cellular reaction, having this vitritis. You can see here there is some form of media haze, then there's a depigmented, this clover leaf shaped chorioretinal atrophy, within which you see this active chorioretinitis, which is marked by these white arrows. Now, this patient basically had a active chorioretinitis within a chorioretinal atrophy, along with vitritis. So this patient, when investigated systemically, had tested to be positive for MON2. He had X-ray suggestive of opacity secondary to pulmonary TB. Then his PCR on vitreous sample also tested to be positive for MTB. The patient was started on ATT for 6 months. And what happens after treatment is there was resolved vitritis, the retinitis patch resolved. And now what you can see is just this depigmented patch of chorioretinal atrophy. Now, this experience happened again and again when someone saw that possibly, this is something which is common to these TB patients. So that is how, by these repeated learning experiences, we came to a conclusion that probably this can be considered as a specific sign itself pointing towards the diagnosis of intraocular tuberculosis, especially in a TB endemic country like ours. So now let me take you through the final example of the creative thinking is that of this 62-year-old diabetic male. Now you see he underwent cataract IOL surgery 9 weeks back. His vision is good, 20/30. Anterior chamber shows a cellular reaction. You can see this hyperpane, basically feathery, browny exudate, which is there, right? Because of its margin, this itself, the structure itself, that probably it's fungal, but it was also confirmed. So this sample was taken and tested, and it came out to be a fungal endophthalmitis. uh, basically a low virulent delayed fungal endophthalmitis, which was again treated. So the even the if you see in this picture, the iris was excised, but still, if you see, it kept coming back in the form of recurrences, despite being treated with the intraocular antifungals, systemic treatment. And the patient did not want to get rid of the IOL. So that was the problem here. Now the patient, because obviously the vision was good, so what we did is we tried doing a cryotherapy to it. So cryo application was done, covering 1 clock hour on either side of this exudate, this area. And after this cryotherapy, successfully, we could get rid of the fungal infection without having to actually remove the intraocular lens. So, and then this is already published in literature. So this is how one can, with your experiences, try to see if something works, something, try to be novel in your approach. So this is what is creative thinking. Now, taking what we learned from this case, there was this another lady who had this infectious scleritis, who was going into panophthalmitis and was in a lot of pain. Despite taking samples, trying to find out what is causing this organism, nothing was getting picked up. So then we thought, okay, why not let us try to apply that same thing which we learned. We did a same procedure, did the cryotherapy for her. And with cryotherapy and the systemic antibiotics, slowly we could get rid of the infection. So this is how learning from past experiences helps us in our clinical practice. So let me give you a few key takeaways from this presentation. So convergent thinking is putting different pieces of information in a logical and an organized manner to reach an appropriate diagnosis or conclusion. However, creative thinking is the ability to consider something in a new way. It includes analysis, open-mindedness, problem solving, organization, and correct communication. So let's reflect what convergent thinking. I took you through 3 cases, each one of exudative retinopathy, where the patient VKH versus posterior scleritis, and we did how we logically came to a conclusion that probably it is posterior scleritis more than VKH. Second was that of a CNVM, where how history and physical examination helped us diagnose CNVM. It's not just a simple CNVM, but an angioid-streak CNVM secondary to Paget's disease. And third, of a post-op endophthalmitis, where we tried to converge our thought process and were able to find out the source of this infection. The second part of the presentation was on creative thinking, where we dealt with the novel sign of parafoveal telangiectasia, that how with someone trying to, you just need to observe, you keep observing and you'll be able to find out that probably something here is different, and you keep looking for it and you'll be able to find it. Second example was that of how chorioretinitis became a specific sign of intraocular tuberculosis. And third was regarding the use of this cryotherapy in cases with recalcitrant endophthalmitis. So once again, before we go to the next session, let me reiterate which were the 6 types of thinking. First was concrete thinking, which is thinking in its simplest form. What you see immediately and what comes to your mind is concrete thinking. It has nothing beyond that. Abstract thinking is when you try to put a picture to it, when you try to reflect it, when you try to think or try to compare it with something or what it symbolizes, is abstract thinking. Analytical thinking is breaking down a given clinical picture into parts and trying to understand what it says, and that makes your job very easy to come to a conclusion. Divergent thinking involves creativity. You need to think of multiple possible solutions that can be for a given problem. However, convergent thinking was, now how do we come to a single best conclusion when you have so many options there? So it involves logical reasoning. And finally, creative thinking is thinking outside the box. Just have an eye for it, keep looking at it, keep observing, keep learning from your past experiences. And creative thinking is, again, once again, I need to tell you that it's a skill we all can nurture. So we saw about concrete thinking, a simple example of CNVM, abstract thinking, the example, Anamika told us the example of how a horseshoe is there, for how horseshoe tear was named as a horseshoe tear. Then analytical thinking is breaking down this picture of CNVM, where there are presence of these pure day orange appearance, angioid streaks, and not just stay at CNVM, but try to break that picture and look for a cause. Divergent thinking about looking for different possible solutions which could be there to a given problem. Convergent thinking is how here we came, CNVM is not just CNVM, but a CNVM secondary to Paget's disease. And finally, creative thinking is you keep learning from your past experiences, keep making new observations, keep observing, and you'll be able to, develop this skill within you. So with this, before I conclude, let me leave you with this question to ponder over: what is critical thinking? Thank you.
Thank you very much, Prabhjot. That was another